It's Healthcare Unfiltered, and we've got kind of like two first timers here that are coming on Healthcare Unfiltered. There's a rumor, by the way, folks, that the sole reason they're coming on the podcast is because they want a t-shirt. And I very much, I mean, Emil, you do look stylish in the t-shirt. You just have to tell me it's like you want black or gray,
Mhm.
and you're gonna style it. And Shruti as well. I mean, just I need black or gray, but genuinely welcome to the show. I really appreciate. I know it took a lot of time to schedule this, but this means a lot because our focus is about cancer in younger folks, using GI malignancies as a prototype to what we are going to talk about. And we were hoping also that our colleague Shalon Beg is going to join us, but we don't like Shalon. His actually, honestly, I think he I can't believe I even had him one time on the podcast.
Mhm.
Yeah, it's
Um,
shocking. It's
Do you
shocking.
appreciate the t-shirt? Because rumor
no,
confirms
I'll
we are
never
out of
send him. I'll
t-shirts, but did you
never send
appreciate
him a
his t-shirt?
t-shirt.
Yeah.
I've
I'll
never seen him
never.
in the t-shirt, so
Yeah, and I think he
Yeah,
has like some weird presentation at AACR, and now he doesn't talk to any of us. Kind of.
exactly. Yeah, no, it's like hard to get a hold of this guy, so he's off
super.
doing special things for the inside.
What's nice about you guys, though, you're now influencers. We're gonna talk about that a little bit because all I see you all over Instagram and everything. So we're gonna start just a bit with introductions as to what you do and maybe share a bit for listeners and viewers what got you into oncology or GI oncology to get a little bit about this. And then I want to go into this influencing social media, Instagram stuff, and then we get some science. Shruti, will start with you because you badmouth Shallon Beg the most. So you start.
Amazing. I'll take it. So I'm Shruti. I am a new junior faculty at Stanford, and I work at the VA Palo Alto as well. And I see patients with GI malignancies, and kind of a little bit about how I got into GI specifically has to do with actually cancer of unknown primary. Why? I was going to be in OBGYN when I was a third year medical student. I know, both of your faces, shocking. So much so that I wrote about how I was going to be an OBGYN in my medical school personal statement. I was really committed. And then I started my rotations and I took care of a patient on my internal medicine rotation who had a cancer of unknown primary. And it's like, not to be dramatic, but it changed my life where I felt like there was so much that I wanted to do for her, and she ultimately ended up passing without getting chemotherapy, and it really just it shifted everything for me. I think I went into oncology because I think you can do so much for someone, and the science is just really remarkable. And that patient specifically, she had liver mets, and and they thought it was a GI primary, and that's kind of what really got me into GI specifically, to answer that question. And then we can talk about the social media thing maybe after Emil's up.
And you're not being dramatic. I think a lot of us have personal stories, and I think that's really there's a human element of oncology that I think a lot of us are drawn to. And then the science comes next. Honestly, a lot of people I talk to, there's a human element before the science. Emil, a bit about you.
Yeah, yeah, I confirm I am here for the t-shirt, so thank you for just acknowledging that at the outset. And so I think, we've talked about my path before, and echoing what Shruti said is that, I think it's kind of convergence of the science and the human element, and that for so many of us that go into the cancer care field, and I'm no different in that respect. So I entered medical school knowing I wanted to go into oncology, and not to say anything was particularly special about me, but I was just fascinated by the science at a time before the explosion of science really making a difference in patients with lung cancer, stage 4 melanoma, all the things, and we're going to talk about some of that during this time also. But also friends and family affected by cancer. My best friend's mom died of pancreas cancer after our first year of college, and it was so early on that a drug commonly that's very common. It's like in the water, gemcitabine. Everyone knows about it. By the time it was kind of experimental, and she went down to the NIH for a clinical trial, and unfortunately, she's succumbed to that disease, and it affected me a lot because it affected my friend, and then other family members and other friends, and unfortunately, like everybody cancer is so common, as you said, Chatty, that everyone knows somebody. It could be, you know, a close family member or a neighbor, someone you know at school. But now more and more, as you said at the outset, it could be people of our own generation rather than, you know, someone who's so much older than us in their 60s, like grandparents' generation. Then it becomes more parents' generation. Now it becomes our peers, young adults who are affected by that. So, um, you know, I think all of our careers are somewhat like the long and winding road that the Beatles sang about. And so we
Absolutely.
take twists and turns, but at the end of the day, we're here trying to learn more. We're all in it because we're trying to help other human beings who are affected by this thing called cancer.
And Shruti, just so you know about Emil, he's now a tenured professor. So basically what that means, when he became tenured, I called him or texted him and I was congratulating him.
Mhm.
He said, well, guess what? The good news about this, I can just elbow people in the hallway right now and nobody can say a word. Like I just can, that's it.
there's
With impunity.
there's no rules anymore.
That's it.
Exactly.
That's
No
it. You get that, you're
Handcuffs are
done.
off.
So you guys, I mean, um, during ASCO GI, which just happened several weeks ago, you were kind of all over social media. How did this come about, Shruti? Like, you know what? Like, was it on Live? On like what platform and what were you tasked to do? Because I mean, my Instagram feed was just literally the three of you. I'm like, at some point, I'm like, okay, I need like some other reels.
Yeah, so basically, it was all thanks to Emil. He got invited by Live to kind of do a takeover of their, platform because he has historically, and he'll tell you about it, is very good with this with social media and kind of posting about updates and things like that. And he knew that me and Shalin were interested in kind of doing similar things, and we made some really fun reels back in at ASCO last year, and that's actually how we met last year at ASCO because I was their videographer for a really funny reel, and so he emailed us and was like, "Hey, do you guys want to do this together?" And we were like, "Yeah, that'd be great." And that's kind of how it got started. Now the angle of the only oncologist in the building, that we were kind of just thinking about how we could make it fun, I guess. Emil, what do you think?
No, 100%, 100%. So I'm in turn gonna turn around the credit back to you, Shruti, because at the ASCO annual meeting, you know, so Shalon and I have known each other a long time, but we got connected through social media. So, you know, we were following each other, but we didn't know each other personally. And then he sent some really nice messages. I was kind of experimenting with Instagram, and then I was on the social media working group for ASCO, and I nominated him, and we were chair and co-chair respectively. And we got to experiment a little bit. And then a little fun fact, and Shruti knows this, I take credit with him that we pushed ASCO to enter the 21st century and get an Instagram account, which is now very popular because when you follow during the meetings, our international colleagues especially just have a lot of fun with Instagram in a professional way, but a fun way. And following them has been very, very inspirational. I think a lot of people have taken suit. So when the three of us bonded at the ASCO annual meeting, I think that was a start. And then to me, there was no doubt in my mind when Onclive reached out. It was very nice. They actually reached out to me about ASH. I said, "Well, I'm not a hematologist. I'm not going to be at ASH. I
Send
will
them
be
my
at
way. Send them
ASCO.
my
I
way.
totally will send them your way. I totally will. Yeah. So I think they were grateful to like for me to take on anything. I'm like, I don't know anything about malignant hematology anymore. If I ever did at any point in my career, but I know some stuff about GI, and I'll be at ASCO GI. So ask me again, and they did follow up. So there was no hesitation in my mind. I said, I gotta reach out to my people here.
I have to say
So
though,
it was really
it was very
great.
nice. It was very
Yeah, yeah.
nice. Like
But in turn, I also have to say, you know, as we thought of the fun themes, Shruti came up with the modeling after the Hulu series Only Murders in the Building, Only Oncologists in the Symposium. Only we go by hashtag only oncs, only oncologists in the symposium. We're very adaptable, only oncologists in the building, depending on where we are. But I think it's a fun way for us to kind of just kind of go and launch into the theme of how to be detectives and looking into the mysteries of young onset early adult cancer and
what
other.
are you able to get like feedback, like you know how many clicks? Like are you would OncLive go back and say, um, you know, this is the impressions, things like that? The reason I ask is because this is kind of like direct feedback. It gives you
Mhm.
idea what's working, what's not working.
Right, right. I mean, with the immense number of followers that Enclave has, tens of thousands. So interestingly, my at my unit, my institution, they put like a media report if anyone's mentioned, and they'll say impressions. And I think the Enclave had like, I'm not sure if it was impressions or reach, but it was like 80,000. That's
Wow.
exponentially anything more than I guess I would have as an individual. So, but it was nice. I think it just allowed us a platform to amplify what we want to do. We used Blue Sky. It really took off in November 2024, I think for many reasons. And that's another platform that a lot of scientists and now more clinicians, including oncologists, are taking advantage of. A lot of institutions and journals. Of course, there's still X, what's now called X, but formerly known as Twitter, like kind of like Prince, Instagram, and others. So Enclave allowed us the use of it, and they were very supportive. And we were able to harness that to kind of amplify some of the things that we were hearing at ASCO GI.
Shruti, are you on TikTok? Are you a TikToker?
I am a TikToker. I
We
am a
should follow each other. There you go. I'm
We
on
are
TikTok too.
amazing. I am a TikToker. I'm more of like a recent TikToker and
Me too.
a recent Instagrammer. I think that it's especially in this time, like incredibly important for clinicians and people who really care about science and data to be putting that information out there for people to like listen
Yeah.
to and hear
Yeah.
about in a way that's easy to digest, because
Right.
the papers that we read, they're very complicated. It's very easy to get convoluted. I frequently have to like read things over and over again, and so I think we need to be accessible, and we need to kind of move away. I see Instagram as a way for doctors to move away from a "I told you so," like, or not an I told you so you should do this.
Right.
I'm you should do this because I think it's correct. It's like now we live in the world where people want to know why, and I think that's good. I think it's really good for patients to want to know and should know why we're recommending a certain treatment option. What happens if what we know happens if they don't take a treatment option? And to me, that's kind of how I see Instagram and TikTok is, if I know something, I want people to know about it. I want my patients to know about it. I want to know potential patients, anybody, to
Right.
know about it. And there is a lot of misinformation out there. And if we're not there, how do you combat it? And so to
Right.
me, that's kind of why I got on Instagram, why I got on TikTok, is because a lot, what do I do in my downtime? I scroll, right? Like that's
Right.
just the
Right.
reality.
It's very effective way, and I think as somebody who watched a lot of the reels that you did, the key is to be engaging, short, not like long and direct to the point. So I think you have done amazing job. Shalon did not; he was awful, but both of you have done amazing job. So Emil, I want to talk about cancer in younger folks. That's really, and I know we're going to use GI cancers as a prototype, but how do you define young? Like, is it, I'm not going to give you clues. Tell me what's young, what's old.
As I get older, I think it's anything younger, anyone younger than me. But as I'm getting older, crossing the threshold. But it's a good question because I think colorectal cancer is the paradigm, but it's definitely not the only one. I think we're talking about it because we're helping patients with GI cancers, and so we're closest to that. But the research, the epidemiology, and really the tipping point has been these American Cancer Society. It's this time of year between January and March, they put out the statistics. They get a lot of news, and the news outlets grab hold of it. And so um, I guess it depends. I feel like young onset, all early adult colorectal cancer, sometimes, most often it's age 50 or younger, but I think some of the ACS studies, when they kind of parse out, will say 55 or younger. So it's suffice it to say 50 to 55 or younger. Whereas before we used to quote the average age colorectal cancer, like a range 60 to 70, lung cancer. I mean, we kept on saying, right, through all of our training, right? I would say, safe to say for all of us, cancer is a disease of aging, and it's no longer the case. I mean, that's putting aside pediatric cases of cancer, right? Because there's something else going on there. But to have people in their 20s, I mean, even teens, because I've had patients with colorectal cancer in their teens, but more so 20s, 30s, 40s, 50, and then early 50s that we're calling young adult, early onset cancer. what was really striking, just in the last, I'm broadly reviewing something in depth, in like 2 sentences, but in 5 years, they were saying the incidence of colorectal cancers in the U.S. for age 50 to 55 or younger, 2 to 3-fold higher for people born in the 1990s compared to the mid 50s. That's very striking, right? It's not a small number.
Yeah. Shruti, do you agree with that definition, 50-55? That's one. But number two, are we specifically noticing cancer in the younger group in colorectal, or Emil is using it as an example? In other words, does this translate into pancreas, bladder, whatever it is? I know we get your GI in college, we're going to use that. But when we talk about cancer in younger folks, are you saying that this is only being observed in colorectal cancer?
Absolutely. So my just to mention the first topic is, yes, 50 to 55 is kind of what I think about, but I do know that some people kind of think about early onset X cancer, whatever you want to call that cancer, whichever cancer, based on screening guidelines. So there's definitely some people that are kind of making the push now to say, oh, is early onset colorectal cancer now before 45? Because screening guidelines just changed, a few years ago, saying that colonoscopies start at 45. I don't know, I think I still would consider, 49 and below, but I think it's kind of a good thing to know about, that there is some controversy. If you look at the studies, some studies are just looking at, AYA cancers, which is up until 39 years of age. So standardization it's a great question that you've asked us, because there isn't very, I would say, good standardization across the different cancers. And I recognize that it is a little bit difficult because of screening and things like that, and because AYA is a little bit different than early onset. And so I think it's.
But are we observing the cancer in younger people, regardless of age, only in colorectal, or are you guys seeing that we are seeing cancers in younger individuals across all GI cancers?
It's across cancers. It's across most cancers, I would say. I would not say all of them. I don't have the details off the top of my head, but I do believe that cervical cancer has gone down, HPV, all of those things.
Okay.
But it's not just colorectal cancer. I would say actually a huge component to that number, I'm sure you saw in the media, 82% increase in cancer in young patients. People magazine had it, everybody was on every single Instagram, even the non-medical, non-news Instagrams. And if you actually look at the data, and Emil and I looked at it kind of while we were at GI ASCO pretty extensively, a huge proportion of it, I would say almost half, was actually breast and thyroid.
Yeah.
And so, and so that's a bit, that's interesting. And the thyroid part of it is, I think, extra interesting, because that really plays into how good of our imaging techniques and our surveillance techniques have gotten. And a lot of times thyroid malignancies are considered, I don't want to say benign, but not clinically relevant.
Yeah, it's different.
Right.
It's different.
And so not to underestimate it's absolutely, there's an increase in pancreas as well in younger patients. There is increase in cancers that are extremely harmful, fatal, dangerous, absolutely. But those really large numbers of like 82% increase in women who, and those numbers, I think it's really important in the same vein to say that, cancer deaths are down. And so the question is, are we catching things earlier and, treating them? I hesitate to really perseverate on that, because I don't want to ever make it seem like a curable cancer is not as serious as an uncurable cancer. But I think that's an important distinction to remember when we're looking at rising rates of cancer, hugely rising rates of cancer in this population.
Okay, so Emil, I want to delve deep into this, because I know not all cancers are the same. Obviously, we all know that. Most people have read my book, The Cancer Journey, so they know that. Why are we seeing this? How much of this we just are screening and screening and screening so we see more versus something else? Why are we seeing cancer in younger people? And back when I did residency, way before both of you, the definition of older, by the way, was above Medicare age. Seriously, was like, in any paper, it was arbitrary, but it was, if you're over 65, you're elderly because it's Medicare age, and this was arbitrary. Like nobody, and the screening, I think, was 55 at some point. Like there's a lot of things.
Right.
Help us understand between both of you. Maybe you can take turns trying to give us reasons why we're seeing that.
Yeah, no, trying to make sense of something that you know is very striking. I'm struck in my own practice, and when I hear stories of people who are young adults and don't have symptoms, and then they get diagnosis, right? So in 2018, the American Cancer Society and many other societies followed suit and brought the age down for recommended first cancer screening in the absence of symptoms from 50 down to 45. So that's a 5-year gap, and then you start to meet people that 10 years ago, they would have not have gotten it. They didn't have symptoms. And then age 45, 46, 47, and so on, they're getting diagnosed. So it makes you think, well, I mean, did the early screening save their life? If they had waited until 50 and been very diligent, they turned 50 and the next day they're going in for colonoscopy, would have been found, but how much more at an advanced stage, right? So it's really, there are a lot of unknowns there. But I frequently tell patients, because it's a common question that people ask, but even if people don't ask it, I bring it proactively, and they'll say, yeah, I did wonder about that. I say just outright, because people want to know, is there a genetic or germline hereditary component? I say in general, for the patients that I treat, which are primarily patients with GI cancers, I'll say 5 to 10%, or safe to say under 10%, which means it's not, I say overtly, it's not 50%, it's not 90%. It's a small number compared to what the average lay person might suspect, and probably a lot of physicians too, including us. So that means 90 to 95% environmental. And then about tobacco, we know about alcohol, even just guidelines from ASCO and other societies in the last 2 years, talk about alcohol as a carcinogen. The Surgeon General, the outgoing Surgeon General, in his last few months, before the changing of the guard, emphasized 7 cancers: breast cancer, colorectal cancer, and others, that alcohol, is a heavy carcinogen for those. But it still doesn't explain all the others. And I'm thinking, and I'm still trying to wrap my head around it, Jetty, is that what's different? I'm coming back to that 1950s and then 2 to 3-fold higher incidence for people born in the 90s. So if someone's born in 1990, how old are they now, right? So they're a young adult, right? They're well under that 50 age threshold, right?
It's me.
Yeah,
I was
and
born in 1990.
and our colleagues, I'm like, what's different? But what if you're, quote, doing everything right? And we've all had patients like that, right? They'll say, but I don't smoke. I rarely touch alcohol, if ever, only on New Year's. I don't do drugs. I bike 8 miles. I'm quoting patients I've had, young adults. I bike 8
But there
miles a
should
day.
be an
Why do I have cancer?
explanation, though. There should be. I mean, Shruti, there should be like I'm trying to, like, there are way fewer smokers today in the U.S. than 40 years ago.
Yeah.
So I can't blame smoking. Obviously, there are other environmental things. So I hear what Emil is saying. I'm not 100% convinced yet.
Okay, so I think what Emil is saying, though, is just kind of leading up to, I think the top line is going to be deeply unsatisfying for you, Jenny, because the top line is we don't know, right? That is the top line. Now, of course, there is no shortage in theories, right? So we sit here and we can talk about, I would say, food, like processing, maybe that has changed. Red meat, things like that. But again, to Emil's point, most of my patients who are in their 30s, 20s, who have gotten cancer do not have these unhealthy, quote unquote, unhealthy, what we call risk factors. And so another thing that, Emil, I'm actually going to let you take this one because you're the one that loves to talk about this. But I'll tell, after you talk about it, I'll tell a quick story about the tea bags at ASCO GI.
Yes.
But I'm gonna lob this to you because I know that you want to talk about it.
Go ahead, Emil.
Yes. 2024 for me, from the lab research standpoint and trying to unravel this and kind of try and meet the middle is I just feel that there's in the zeitgeist, non-cancer related studies overwhelmingly are telling us. So now that I said all the stuff that we know about, here's a postulate, here's a hypothesis, but it's building in other types of diseases that I think is going to be central to this young adult early onset cancer. The environmental exposures of things in fertilizer, but plastics. So microplastics and nanoplastics, we all use plastics. We have all in our lifetime, probably safe to say more than once, had drew junk water from plastic bottles that are throwaway and hopefully get recycled. Use plastic utensils, Tupperware, to whatever equivalent these days, the Ziploc brand or whatever it is. But the idea that if it's thrown away, it leaches into the environment. If you put it in a dishwasher, it leaches off, exposed to hot water. You go to a restaurant and you put hot food in it. It goes in like the microparticles and other things. It's
Interesting.
called a sustained delivery vehicle. Is kind of a term used a lot in biomaterials that I think applies to microplastics and nanoplastics. And the more I've delved into this, and it's literally just in the first part of 2025, but going back over the last year, there are studies that, whether on autopsy or others, that in the coronary atherosclerosis world, there will be a significant proportion, 10 to 20% of patients that they will find linings of the coronary arteries with microplastics, nanoplastics. The tea bag, that really is, I obsessed over this, and I share with her at Shalon as for the only oncs, is that a fascinating study came out end of 2024. Granted, a basic science study, but you ever have tea bags? I mean, I'm Persian, so we love our
I'm
tea.
drinking tea, by the way.
I was gonna say.
In the metal balls or tea bag. But a lot of tea bags have sometimes you go to a fancy conference and they have the beautiful plastic, shiny plastic.
Hmm.
That plastic, when you put the tea bag into hot water, this study, I mean, this is where mind blowing, was shown to shed, and these are like common brands you would buy off the shelf at any supermarket, 1.2 billion or more microplastic and nanoplastics into your cup of hot water that is supposed to become tea when exposed to hot water. But can you imagine? I mean, billion. And so if you drink one cup of that, I know there have been some studies in physiology that said, well, how much can the human body take and eliminate it or whatever. But I just cannot stop thinking the last few months about 1.2 billion from a fancy plastic tea bag that was amplified for me in a recent Nature paper that said, from autopsy samples in brains, the equivalent of microplastic, nanoplastic, enough like gram-based weight that would be equivalent of like a plastic spoon. If that were chopped up into microplastic and nanoplastics, human brains were containing that. And it wasn't necessarily people who have died of seizures or severe disease, but that to me, that's frightening. And that's a vast unknown. Um,
So, Shruti, is Emil alluding that the overuse of plastic is leading to cancer in younger folks?
So that is actually one of the leading theories, right? Everybody thinks that this is multifactorial. I think plastics is one of the kind of thoughts, and because we're trying to, I think all of us who are interested in this space are trying to think of something beyond diet and exercise and alcohol and smoking. And I think that a lot of the media and the research up until this point has really focused on those, I would say, four things, and then eating like processed foods and things like that. And I think the reason why it has focused on that is because we as humans, we want control, right? We want it's kind of a lot more difficult to say, the environment has leached these plastics. We have no control and you might get cancer. Nobody likes that. I don't like that. And I'm an oncologist, right? But the reality is that anybody can get cancer. And I think that is an extremely, extremely difficult pill to swallow for people, humans, just everybody. And so I think that initially when these trends were coming out and people were trying to understand them, I think kind of grasping on to its diet, its exercise, it's kind of things that we can change. Oh, if you eat better, you won't get cancer. If and I think now people are starting to realize, and have obviously that people have been doing this work for years. But I think it's becoming more mainstream that people are starting to realize that there's something bigger going on beyond people just eating healthy.
Yeah.
And so and something that we haven't mentioned yet is the microbiome. So I do think that there is some research that is going on that is looking at a particular type of E. coli that might not preclude.
Prevent.
No, not prevent. Actually, make you more susceptible. Sorry, just word enhance word farted there on the podcast. But might enhance or kind of increase your risk of getting young onset colorectal cancer. And so these are kind of the things that are kind of the leading theories. You have your microplastics, you have your gut microbiome. Yes, we agree that it is possible that diet, exercise, and those alcohol, smoking all increases your risk of cancer. But I think everyone who takes care of these patients thinks that there is something else out there that we don't know. And I think that's why these investigations are so critical. But again, I'm going to just reiterate that these are all theories, and I think that no one has really honed in on the answer yet, and it's extremely unsatisfying.
I'd like you to think a bit more about diet, though, both of you, since it's your area, because obviously I was involved. I wrote a book on this toxic exposure, which is the impact of glyphosate and pesticides. And glyphosate is an herbicide that's sprayed all over the crops and everywhere. So it really allows pretty much it's in your food, cereal, bread, everywhere. And glyphosate is an herbicide. There's been actually it has been shown to in some studies to increase the risk of non-Hodgkin lymphoma. I certainly believe it does, and it contributes and it causes non-Hodgkin lymphoma in some people. And it makes you wonder if there's really more to it, because it's the most used herbicide in the world. It's sprayed all over. That's why some people try organic food, or they go to the farmer's market or things like that. So you alluded to this with processed food and other things, but we have to think, these were not used ubiquitously like now. So it makes you wonder, no?
Absolutely. I think, to be clear, I don't think that it's not diet, right? It's not the foods that we're consuming, and it's not, I think ultimately all these environmental exposures, the world is not what it was 50 years ago or 70 years ago, right? So I do think that absolutely plays into it. I think the thing that I feel really strongly about is that it's not the only thing that contributes to it. And so I think that there is sometimes a general desire to kind of be like, this is what it is. Because especially because then if you eat organic and you are always cooking your meals at home and you're never eating out and you're not eating any processed foods, you might think that you won't get cancer. And that I think is also harmful, because we know that can still happen. And so to me, the only thing that I'm really trying to emphasize, and I'm sorry if I didn't kind of make that clear, is that it's not only kind of these kinds of things. But I really appreciate you bringing that up, because I didn't know that about that specific herbicide. But I do think that
I think it's worthy of taking a look at. So, Emil, you're a physician scientist. I know that all of you are scientists, but you're more entrenched in the lab. Shruti, you're not in the lab. Are you in the lab?
Not in the lab.
Yeah, but I mentioned that because Emil is a very successful lab. I've always admired him being able to do both. How do you put on your lab hat? You're seeing a phenomenon, right? Okay. How do you investigate this? What do you do to try to get to the bottom of it?
Yeah. And we're very much trying to do that. And so, of course, everything's intertwined with funding, but putting the funding question aside, as we hope to kind of be able to build on this, is that, I'm very interested in how things happen at a cellular level, because I think it's just a basic building block. If you don't know what happens with individual cells or clusters of cells, and of course, how they network and communicate and do something, I don't think there's a way to know at a full organ, a full human, let's say the host tumor interaction level and beyond. There's no way to know that. So I think literally looking at things under the microscope is essential. And some of the things, just as an example with this microplastic issue, and talking with some bioengineering colleagues, just people completely outside the sphere of even just like pure biology or oncology, they're just saying like, I guess it's really me asking, teach me about microplastics and nanoplastics and what are the biophysical properties that they have as synthetic materials and how would a biologic entity like a cell even take it up? What would determine that? And like things like literally talking about things that involve things from calculus that I long ago forgot, but like stiffness and engineering basic properties, even just attacking like that. That's some of the ways we're trying to attack it. But in this era of molecular oncology, we focus so much on genomics and saying, well, the genes are this and this, that. And I said earlier that under 10% are potentially hereditary. But even though there are some studies, again, just using colorectal cancer and then some others as an example, um, I guess the premise and the supposition people assume that there has to be something genomically, quote, more aggressive, although I don't like to use that term in general, is that it's something very genomically different about the young adult cancers, colorectal or otherwise, than not. But the studies are not really bearing that
Yeah.
out. We did a large genomic study, and so many others have done, and there's not like a twofold more KRAS mutations in colorectal
Right.
cancer in an older population versus younger. So it's not all explained by molecular biology. But I'll say, I know we're talking about plastics. I think that's just one component, but I want to use it as an example of something that people are not knowingly being exposed to, but we also don't control, right? So if plastics of any kind leach off into the drinking water, for example, not to scare anybody, nobody's saying this, but if that's a fact that wherever things are in dumps and there's leaching off of plastics to get in the water, that's not something that's in my control, whereas smoking tobacco, drinking alcohol is something I can choose to do or not to do. So like when I think of, I was taught in medical school, so tobacco a risk factor for pancreas, head and neck, lung cancer, alcohol, and I always, learn for head and neck cancer, the two, tobacco and heavy use of alcohol is going to create a 50-fold higher risk of getting head and neck cancer. So it's exponential and synergistic. So now if you just replace those words with microplastic, nanoplastics, and microbiome, I don't think those are separate at all. But I also think another environmental factor, you mentioned herbicides and pesticides. So these are not things we can control, but our food supply, we go to the market and maybe we want to maybe shell out a little bit more for organics if we can afford to do so. But it seems like nothing is safe these days. Another theme of 2024 was, that term forever chemicals. And with exposés, even in our own backyard in Minnesota, 3M, which is very prolific, these things have been known for decades and they've leached off into communities and we don't know about it. PFAS. I was alarmed by a New York Times article in the summer of 2024 talking about PFAS in the fertilizer. And I don't have a way of knowing if that's in the food that I buy at the supermarket and ended up
Right.
cooking, but that's something so scary to me because we don't have any control over that.
Right.
Now we're
Right.
going from things you can control, and if I don't do these things, then I'm going to have a less risk of cancer, supposedly, to things that are uncontrollable or unknowable.
Very helpful. Shruti, let's move a bit to ASCO GI and maybe what have you seen out there, that data that you would like to share with viewers and listeners that are either instrumental clinically, but also related to the theme of younger folks with cancer. Have you seen anything, whether it is treatment related, whether it is pathobiology, whether it is anything you want to share from the ASCO GI 2025 meeting?
Yeah, so I think, unfortunately, I got to say that I don't know that I absolutely, there were interesting things at ASCO GI. I don't know if there's things that are really clinically practice changing for patients with young, early onset, any of the GI cancers. I think to just kind of take home Emil's point is that a lot of the GI cancers are not really, genotypically or not, genomically, sorry, different than the older people's cancers. The exception that I'll say is I know that in biliary tract cancers, they do have a higher proportion of FGF2 mutations. And so that is something that is known, but I would say the only thing that we can glean from that is not necessarily anything other than every patient with biliary tract cancer, especially the young patients, but I wouldn't even say especially the young patients. Every patient with biliary tract cancer should get genomic profiling. And so does that change my clinical practice? No, because every single patient I see with biliary tract cancer gets genomic profiling, but it's good to know because I think it's something that isn't done very frequently in our country. And so to that point, there was one study. It was a poster presentation that was done by I think the GI kind of a group of GI patient advocacy groups, and less than 40% of patients, less than 40% of patients get genomic profiling when they kind of surveyed those patients. And these were in tumors that have like targeted therapies. So you have your HER2s, you have your Claudin 18.2s, FGF2s. And I think that that's an extremely important thing to think about, whether we're talking about young or older patients. And that's not really a plenary, that's not going to be on the main stage, but that's actually what impacts our patients. Our patients need genomic testing. And every single patient who has a first line indication of like every single patient with the GEJ cancer needs Claudin 18.2 and needs HER2 testing and PD-L1, right? Because you can't even make that first tree branch of where I go if I don't have those three numbers, or, and so I thought that that was something that I did see from ASCO GI that wasn't really on the podium, but I think extremely, extremely important for any clinician or any patient to even know about, because then you can ask your doctor, like, hey, what about genomic testing? Is that something that's relevant for me? Sorry.
Emil, did you see something that is not necessarily for younger folks that was practice changing? Anything practice changing?
Yeah, I think I'll be honest with you. We're all among friends and all of our friendly listeners.
Hey, and it's unfiltered. You're going to be
It's very
broadcasted
unfiltered.
to
So
thousands of people are going to hear this. Go
I think
ahead.
sometimes you go to a meeting and you're like, wow, and I don't think this year had the wow factor for me. And I think we kind of commented on some more
There
Instagram
will
posts
never
about
be
it.
a wow. You were with Shallon Begg. How are you going to have a wow? For
Well, we
God's
have
sake.
we have to up the gay, right? The
Yeah.
synergy for the three of us, but that's why we have some of the banter to fill in when we don't have anything
But there was
exactly.
nothing like earth-shattering in terms of practice changing.
Yeah. I
Anything
think
specifically struck you in colorectal?
um I mean, not off
We
the top
talked
of
about
my head.
biliary. I think Shruti mentioned the genomic sequencing, very important. In colorectal, anything specific?
What do you think
Yeah, I
about
mean,
breakwater?
yeah, oh yeah, no, I think breakwater. I mean, I think with the BRAF, V600E variant, that's really prevalent in about 5 to 10% of patients with metastatic colorectal cancer. So it's kind of nice because it went from a decade ago for like, oh, it's only a prognostic biomarker. Then it became a predictive biomarker with the Beacon trial and breakwater. I would say yes or no. So
Yeah, right,
I
right.
was thinking of it, but I didn't say
Same.
I didn't
No, but
write
I
on
thought
the
So
I'd bring it up.
tell us
it.
what
That's
breakwater
what
is.
that's what,
We
So
don't know what
breakwater
breakwater is.
is distilling it down to basically saying, yeah, targeted therapy. So I guess when the Beacon study came out, it was the use initially of a triplet therapy, right? So it's a BRAF inhibitor, and then also cetuximab EGFR inhibitor and a MEK inhibitor. But it turns out like three was not necessarily better than two. So the standard became the EGFR inhibition with cetuximab and the BRAF inhibition. So that's been used a number of years in patients, with at least second line or beyond, right? But not for first line. And they kind of graduate to first line. And breakwater is basically the chemo that we used to give anyway and give to everybody else anyway, and they add the BRAF inhibition. No, I'm kind of saying, is it practice changing? Because I don't know that everybody left that hall saying, nodding their head like, I'm going to do this tomorrow. And I'm not sure that I was convinced that way. Although, of course, social media, there's a wide swath where people are like, oh my gosh, this is amazing for our patients. We have to do this immediately. Whereas, I would say a little hesitate.
Shruti, do you share the cynicism?
yeah, I share a little bit of the cynicism in that I'm kind of when you think about taking care of like most patients with cancer, you kind of think about it like guess I think about it a little bit like a relay race, right? Where you have a certain number of tools in your toolkit that you can use to kind of keep the cancer at bay. And so more is not always better. And so I think that initially, yeah, I guess because I think that more is not always better, I really want to see the more long-term data. I think the thing that was really interesting about this, just, I think your listeners might find this interesting as from a regulatory standpoint, is this is the first line accelerated approval. And I think that is extremely, extremely interesting and kind of, I'm intrigued about this opening the door for other first line accelerated approvals. And I have like a little bit of to self cite. I've written an editorial about accelerated approvals and in JCO that came out at the end of last year. And I think that we have to be really thoughtful about the first accelerated approval that we give to a drug. And I think that's because I worry about the phase 3 studies. I also worry about, fast follower drugs. And so to me, the most interesting part of Breakwater and why I bring it up is I don't know that I would say it's practice changing. I think there might be a subset of patients that I would use it for. If I need to get a really good response rate, their ORR was very promising. And so if there is a patient that you really need to get that tumor shrunk ASAP, that might be a good patient to use it in. But I think the interesting part is where the FDA is going with like these first line accelerated approvals is actually more, that's interesting to me.
Yeah.
Anything new in pancreas, Emil?
No.
Anything new in hepatocellular carcinoma?
No.
Upper GI.
I mean,
what do you guys do at ASCO GI, for God's sake? You just went and hang out? Like, what the hell is this?
I will,
okay, hold on. I gotta come in hot for HCC.
Come on, give me some new data. Give me something.
They had an Ipi-Nivo in HCC Checkmate 9 DW. I think trying to figure out where that fits in the market of, you got your Atezo-Bev, you have your Durva-Tremi, is a little bit difficult to say, like where that's going to fit in. But as we know in lung cancer, right, there are many approvals of similar type drugs in the same, and they find their way. And so I think it'll be interesting to see how Ipi-Nivo kind of comes into the market and of HCC, but that was there at ASCO GI. In our defense, in ASCO GI's defense.
Okay. Is there anything? I mean, we've talked about upper or lower GI, hepatocellular, pancreas, and is there anything in terms of screening that was worth mentioning, or anything like observational studies? I know we're not always big fans of these, but screening, you feel genuinely that the field is moving towards screening younger than 45?
Yes, I think so.
But how young can we go? Like, how much of this is like,
I'm a little skeptical.
I struggle with
I'm a little
this, to be
skeptical.
honest.
Yeah, no, I know exactly. I want to give an example. It's not specific to ASCO GI, but the timing overlapped. And I think it has very real world consequences, and it's directly linked to young adult early onset. Right, because when the average age of a lot of these cancers, GI or otherwise, is 60, 70, it's past either for men and women, an age when they're going to biologically have children or think about having children. So now you have young onset, so of childbearing age for women and men who also, their semen can be affected and whatnot, their sperm can be affected. So now you have to have a lot of these. It has to be on the top of our mind to have fertility conversations and get maternal fetal medicine and other specialists involved. There was a study that came out of the NIH, I think it was just in December, by the time it was officially published in the New England Journal of Medicine, that our colleagues in the OB/GYN field borrowed. But we were doing a lot the last few years, hot topics, cell-free DNA, right? But in cancer, we call it circulating tumor DNA, whatever. And all these, that's a hot topic, and maybe it's overused in another episode of Healthcare Unfiltered. Another time we can really be unfiltered on that topic. But
really unfiltered.
No, we definitely have
it has been covered, but we can do it again.
Yeah, cell-free DNA, right? I want to say this right. Cell-free DNA for maternal screening to replace the old method of invasive needle, basically a biopsy, amniotic fluid. But the study at the NIH was interesting because the cell-free DNA was capturing genes of interest that overlap with cancer. And so they took these women who had these kind of results from, these different commercial companies. They went to NIH and they had amazing set of imaging that's not really readily available like PET MRI and these others. And they were saying a large portion of them, more than expected, certainly, were diagnosed with a cancer for which they were asymptomatic while pregnant. And the immense challenge of trying to safely treat someone who's pregnant, and to
Yeah.
not, I mean, it's really the ultimate, primum nocere, first do no harm, right? To not one, but two beings there. But I think it's an amazing use of technology. It intersects directly with that young adult early onset cancer concept. And, that was something that was kind of on my mind, at GI ASCO as you started thinking about that. So when you mention screening, I think we can't neglect that because it's really at the nexus of childbearing age, men and women, who want to have children. What's the safety of the treatments that we give? And I think it's kind of the age-old question that before immunotherapy exploded and it's all me too, I was hoping that the era 5, 6 years ago would be done at GI ASCO, ASCO meeting, or ACR, of A plus B was really good, so A plus B plus C must be even better. And I know that those trials were designed and executed beginning 10 years prior, so I'm like, we're done with that. But what I'm afraid of, I would say offer for both of you to speculate, is that we're doing the same thing, but it's just the Me Too is immunotherapy instead of more cytotoxic chemotherapy. And HCC and the others, the things that bothers me is that these are agnostic of any biomarkers to select out and saying, here are patients. Like it's almost like no effort, no correlate biomarkers are integrated as part of these trials. And it's almost an afterthought. I'm like, well, no, I think we have genomic markers we can test. How about a better effort, whether it's cell-free DNA, circulating tumor DNA, or genomic markers from tissue, or some other testing
or
to
even
select out who would benefit from this stuff?
or even like I do think there are some studies that are now looking at non-liver metastasis colorectal cancer versus liver mets,
Yes.
like
Yes.
even something like that feels like an, not easy, but just from what we
So
know data.
Yeah.
So
So it seems to me that there wasn't any practice changing. That's the summary. But this observation of cancer in younger folks is up there, and you guys are going to work on it. So you're going to come back next year and you're going to show me some progress that we at least have an understanding why this is happening, because we can't tackle it unless we know what it is. And it's okay not to know it today, but it's not okay not to try to investigate further. So you're on
Absolutely.
the hot seat right now because you're all over Instagram and TikTok talking about it. And now we need to go to work by it. So
That's
patience
right.
and want this. So I really wish you all the luck in doing this.
Thank
Any
you.
final thoughts from Emil first and then Shruti?
Well, thank you for having us on because this is a really important topic. Again, we want to make it fun. We want to make it digestible. I think integrating that social media in the social media era where no one's sitting down and just watching us just go on and on for 30 minutes. So we try to make it digestible and fun, but we're trying to educate, right? We're learning, but I think we're trying to educate ourselves and trying to digest it and then share and amplify the messages. We're learning together. So I think, this was a good launch for only oncologists at the symposium. And we're going to continue that. I think we'll continue through the AACR annual meetings. ASCO annual meeting will be really top tier, foundational for us. But I think as we explore, and some of the recent ones we even posted earlier this week, we're focusing on GU ASCO. This is more your sphere than ours, but I think we're just trying to learn. We're oncologists and trying to share with patients. We're trying to share with each other, reaching across the aisle to scientists, and trying to do the best we can to contribute and try to unravel these mysteries together.
Shruti.
yeah, my kind of last thoughts are that is really to anybody, whether it's a patient, not even patient, any person, oncologist, whatever, is is that cancer is increasing in young people, and we can't be. I think it's important to like listen to our bodies, listen to really know. I tell all my friends, know what your poop looks like once a week. Take a look at it. It's weird, but just take a look at it. Like, I think these are things like know what your typical bowel habits are, know what pains you have at baseline in your body. And then if something changes, advocate for yourself, because people might not believe you. That's just the reality. It's really, people still think of cancer as an old person's disease. And so you might have to advocate for yourself, but know your body, listen to your body. And, but also to that vein, like, don't be scared. Live your life scared. Don't live your life scared. Just continue to live your life, continue to enjoy this, I think, beautiful life. And yes, we are on it. We are on the mission. We're trying to really figure out what's going on so we can find a solution. But in the meantime, I don't know. I think a lot of people are scared of cancer, and it makes a ton of sense. And so I tell my friends, like, know your body, like, try to know your body to the best of your ability, and then enjoy life, because that's what it's meant to be.
Well, no matter how long you do it, you're always scared of it. I am.
Yeah.
My ask is that hopefully you can get to investigate a bit of the relationship of herbicide, maybe glyphosate, and look into this a little bit, because it's very, I mean, there's something going on in the environment, in my opinion. But yeah, hopefully we'll know more, and then we can tackle it. Dr. Shruti Patel and Emil Liu on Healthcare Unfiltered, and we don't like shell and bag.
Oh no.
We
Where wait,
I heard Shruti say she
We
doesn't
actually
like.
miss you, kind of.
What?
For the
Are you
record,
retracting?
listeners, we're all good friends.
Yeah, we are all good friends. Oh God.
Yeah, he's been on my show.
He's a
No,
joke.
Shallon, if you're listening, we do love you. We're kind of upset that you were not here, but
That's really what we're salty about. That's
yeah,
why
basically we're
laughing
very
about
salty about this. So Shallon was on my show talking about alcohol and cancer, basically.
Oh
And
yeah.
it's actually one of the most listened to episodes in 2024. Every year I have my top 10, because I tape about between 48 to 50 episodes a year. And there's like usually top 10 based on number of views and number of listens, because I combine YouTube with downloads and things like that. So you have a tall order to overcome in
it. Yeah.
2025. We'll see what happens.
See what happens. All right.
Absolutely.
Thank you so
Thanks
much
so
for
much,
coming
Debbie.
on.